So friends, after understanding the anatomy of the larynx, let us start our discussion with the diseases of larynx. So the first thing that we should discuss is the congenital diseases of larynx. Okay, and the first congenital disease that we have to discuss is laryngomalacia. So what is laryngomalacia? This is the most common congenital anomaly of larynx. Okay, most common congenital anomaly. Now what happens in laryngomalacia? In laryngomalacia, when a child is born, he or she is born with soft cartilages. Okay, so the cartilages, the thyroid cartilage, the cricoid cartilage, so the epiglottis, these are all soft. Now what happens as a result? You see, when we breathe in, what happens? When we breathe in, our lungs expand. So how do the lungs expand? The thoracic cage, it goes out. The diaphragm, it goes down. Okay, that creates a negative pressure in the thoracic cavity. Right? Now that negative pressure expands the lungs. So when the lungs expand, a negative pressure is generated in the lungs, in the thoracic cavity, and that pulls the air from outside. Okay, so remember, inspiration is active. The muscles, they act and then they create a negative pressure that pulls the air. Now this air is flowing in a laminar flow. And we have discussed this in the nose topic also. Whenever something is flowing in a laminar flow, it creates a Bernoulli's phenomena around it. So that means a negative pressure is generated around the airflow. Okay, and we know that these cartilages of the larynx, they are soft. So these cartilages, especially the epiglottis, okay, very free cartilage, and this cartilage and the other cartilages, they collapse inside. So when they collapse inside, what happens? The airway becomes narrow. All right. So when the cartilages collapse, airway becomes narrow. Now the airflow, which was a laminar airflow, it becomes a turbulent airflow. And that turbulent airflow creates a sound, a noise. We call that noise as stridor. Okay. So that is known as stridor. Now, this stridor is present during inspiration. What happens during expiration? During expiration, the thoracic cage goes in, the diaphragm goes up, that creates a positive pressure. Now the air is coming out with a positive pressure and it throws all the cartilages back to its place. Okay, so the airway opens up. There is no stridor. So that means expiration is normal, but the collapse of the airway is during inspiration. So patient has inspiratory stridor right from birth. Okay, so this child has inspiratory stridor since birth. Expiration is normal. So if I say expiration is normal, that means child's cry is normal. Crying is a expiratory process. So cry is normal. Okay, but when the child cries, you see, when the child cries, the child throws out expiratory reserve volume. Remember, we breathe in and out tidal volume. We have inspiratory reserve volume, we have expiratory reserve volume. Now, while crying, the child throws out expiratory reserve volume. So now he has to breathe in more air. More air means more stridor. Okay, more negative pressure, more stridor. So cry is normal. The sound of the cry is normal because expiration is normal, but after crying it increases stridor. Right, the crying increases stridor. So this question is sometimes asked, the child cries and becomes blue. So child cries and becomes blue, that means the crying is increasing stridor. Right, okay. Now if you place this child in a prone position, so when you try to put the child in a prone position, what happens? When you put in a prone position, the epiglottis, it falls forward. So when the epiglottis falls forward, the airway opens up and stridor improves. Right? Okay. So stridor decreases in prone position. All right. Now, how will you confirm your diagnosis? You can confirm it by doing a laryngoscopy. So you see, this is the laryngoscopy we have done, and what do we see in the laryngoscopy? We see a omega shaped epiglottis, right? So you can see over here, this is a omega shaped epiglottis, right? So on laryngoscopy you can see this omega shaped epiglottis. Anything else other than this? You can also see that these airy epiglottic folds they have become flappy, and these retinoid, they become very prominent. Look over here, these retinoid, they become prominent. So we also have floppy AE folds and prominent retinoids, right? So these are the finding on laryngoscopy of a patient with laryngomalacia. Now, what treatment will you advise? The treatment in this case is conservative. Conservative means you advise the parents to nurse the child in prone position. Why? Why? Because when the child grows, what will happen? The airway will increase in size, and these cartilages, they become firm. So this condition disappears on its own by 2 years of age. Okay, so remember, the laryngomalacia, the treatment is conservative treatment because this condition disappears on its own by 2 years of age. Clear? Okay, so this should be very, very important point, and you should note it down. Why? Because this question has been asked, which congenital condition of larynx disappears on its own by 2 years? So answer is laryngomalacia. Okay, now sometimes it may not disappear. So if does not disappear, then we need to do a surgery, and that is known as supraglottoplasty. Okay, so supraglottoplasty. So what is done? Now we prefer to do this surgery with CO2 laser these days. You can also do it with cold steel. So that was earlier method, but nowadays we prefer to do it with CO2 laser because the bleeding is less. So you can see over here, you hold the posterior part of the supraglottis, and then you can cut the prominent AE fold and a little part of the retinoid, and you create a airway. Okay, so you cut and remove this part, and you can create a better airway. So this is supraglottoplasty. It is done to improve the airway if the patient does not improve on its own by 2 years of age. Okay, remember, in most of these cases, the stridor is mild to moderate. Okay, that means some airway is still left. It is very, very unusual, very rare to find that the stridor is severe. In most cases, the stridor is mild to moderate, and that also improves when the child is placed in prone position. Okay, so in most cases the treatment is conservative. Only when the patient will be having severe stridor which is not improving, okay, even by 2 years or even by placing in prone position, that you need to do something. Okay, next we come to subglottic hemangioma. Now what is subglottic hemangioma? As the name itself tells you, it's a vascular malformation. It is a hemangioma. Where? In the subglottis. Okay, so this is a hemangioma. It's a vascular malformation in the subglottis. So as you can see over here in this photograph, there is a vascular malformation over here in the subglottis below the vocal folds. How will this patient present? Now as you can see very well, this mass is blocking the airway, so patient is presented with stridor. Okay, what kind of stridor? Patient has inspiratory stridor. Now, when does the child have stridor? The child has stridor at 4 to 5 months of age. Okay, why 4 to 5 months? It's a congenital condition. Why not at birth? Okay, now you see this child when is born, the hemangioma is very, very small in size. So that's the natural history. At the time of birth, generally the hemangiomas are very small, and they start increasing in size between 3 to 5 months of age. They increase in size, so around 4 to 5 months they will start blocking the airway, and then the child will present with respiratory difficulty with stridor. Okay, so child presents at 4 to 5 months of age. Now remember, 50% of these patients, they have cutaneous hemangioma. Okay, so they have cutaneous hemangioma on the skin. So a patient of 5 months of age, a child of 5 months of age comes to you with stridor, with inspiratory stridor. The child was all right at the time of birth. Now it suddenly develops stridor over the last few weeks. Okay, and you examine the child, you find a cutaneous hemangioma on the skin. So you have a diagnosis in your mind. You are thinking that there is a hemangioma on the skin. Probably there can be hemangioma in the subglottis as well, because 50% of subglottic hemangioma patients also have cutaneous hemangioma. Okay, now how will you confirm your diagnosis? Again, you have to do laryngoscopy like the one we have done over here. So you do a laryngoscopy and what do you see? You see a mass. Okay, so you see a reddish blue mass. So there is a bluish hue, also reddish blue mass. Where? In the subglottis. So you can see this reddish blue mass in the subglottis. Okay, treatment. What treatment can you do for subglottic hemangioma? Now for subglottic hemangioma, the first thing you have to remember is when the child presents to you, you have to secure an airway. Remember, it's a mass. The mass is blocking the airway. Okay, so ABC of emergency management, A stands for airway. So first thing that you have to do is to manage the airway. And how will you manage the airway? You will do a tracheostomy. So if somebody asks you what is the first step in the management of subglottic hemangioma, say the answer is tracheostomy. You have to secure the airway, right? You have to secure the airway. Remember, subglottic hemangioma, the mass is blocking the airway, and the stridor may be a severe stridor. Okay, so these patients, they usually present with stridor, and the stridor in many cases is a severe stridor. Unlike laryngomalacia, remember laryngomalacia, the stridor was mild to moderate. Here the stridor is severe, so you have to do tracheostomy, otherwise the patient may go into respiratory collapse, complete respiratory obstruction. Okay, and now let's say you have done tracheostomy. Okay, so secured the airway. Now what can you do? Now after this, you have saved the airway. There are a lot of options in front of you. What are the options? Number one, you can do carbon dioxide laser excision. You see, it's a vascular mass. Okay, it's a vascular mass in the airway. You don't want it to bleed. You don't want the patient to aspirate blood. So you will do a carbon dioxide laser excision. Okay, you don't want to do excision. What can you do? You can do sclerotherapy. Now this sclerotherapy is actually done by a interventional radiologist. Now what will the interventional radiologist do? He will first do an angiography. He will identify the bleeding blood vessels, and then he will put a sclerosing agent in them and stop the blood supply to this hemangioma. Okay, so that's the sclerotherapy you can do, or you can ask the interventional radiologist to do the emboli those vessels. Number three, what you can also do is you can simply inject steroid. Okay, you can inject steroid in the hemangioma, and the steroid will cause fibrosis, and that will lead to shrinkage of the hemangioma. All right, remember also that by the age of 7 to 9 years, this hemangioma also automatically starts decreasing in size. Right? Okay, so that is the natural history of the hemangioma. It starts decreasing also on its own after 7 to 9 years of age. Okay, now let's come to the next, laryngeal web. So what is a web? Web is a membrane. As you can see over here in the photograph, it's a membrane. Okay, now this web is formed due to incomplete canalization of the airway. So the airway canal formation is incomplete. Okay, and that leads to formation of a laryngeal web. First question asks, most common site of laryngeal web formation. So as you can see, the most common site is anterior glottis. That is the most common site for formation of these laryngeal webs. Now how will this patient of laryngeal web present? You can see in the first photograph, this web is completely blocking the airway. Only a small airway is left posteriorly. So what is the problem with the child? The child has stridor. There is an obstruction for inspiration as well as expiration. Okay, so the obstruction is both during the inspiration phase as well as the expiration phase. So this patient will have biphasic stridor. That means both during inspiration and expiration. Okay, the patient has biphasic stridor, both inspiration and expiration the patient will have stridor, right? Okay, now what do you find on examination? On examination, you can see that there is a membrane which is blocking the airway. Now remember, if you look in the photographs, there are two types of membrane. So similarly, there are two types of laryngeal web. Which two types? Congenital or acquired. Yes, so these webs can not only be congenital, they can also be acquired. So congenital, I told you, was because of incomplete canalization of the airway. Acquired, why do we have acquired webs? Acquired web is generally due to trauma on vocal folds. Okay, when both the vocal folds have a raw area. So the growing epithelium may lead to the adhesion between the two focal folds and we have a acquired laryngeal web. So the congenital webs, these webs are generally cartilaginous webs, whereas the acquired webs, these webs are generally membranous webs. Okay, so membranous webs, you know, a patient is intubated, is in the ICU for a long term, and you know the patient is semi-sedated, not completely sedated, and he moves the head like this. So when he moves the head, the vocal folds, they rub on the endotracheal tube. Both the surfaces, they become raw. So they can lead to a fusion. Also, if you do surgery on both the vocal folds at the same time, again they become raw and it can lead to fusion and formation of acquired laryngeal web. That's why whenever we do surgery on the vocal folds, we do surgery on only one vocal fold at a time so that we prevent formation of these laryngeal webs. Right? Okay, treatment. What treatment can we offer for these laryngeal webs? We have to excise the web. The best way to excise the web, to cut away these webs, is by doing a surgery, a carbon dioxide laser excision, CO2 laser excision. Why? Because that will lead to minimum scarring, sharp margins, very quick healing. Okay, so we can do a CO2 laser excision of the web, but there is a problem. What's the problem? Suppose I have cut on both the sides, I have taken out the web. Now both the sides have raw margin. They can again fuse and form a laryngeal web, isn't it? Yes. Okay, because I have cut the web, obviously there will be raw area on both the sides. So what will I do for that? For that, I have to put a silicone keel. So what's a silicone keel? A silicone keel is a spacer. It is placed between the two folds, so it prevents them from meeting each other. Okay, so this is placed for a few weeks to months depending upon how much raw area and how much scarring is there, and once the healing is complete, then we take out this silicone keel and the two vocal folds, now they have healed, so they will not fuse and form the web again. Right? Okay, now before I go ahead, there is some physiology that we must understand. Now before we go ahead, let us come back to this photograph. Now this photograph shows you the whole airway right from the nasal cavity to pharynx, larynx, trachea and the lungs. Okay, now what happens during this whole respiratory process? You see, during inspiration what happens? During inspiration, as we discussed, the diaphragm goes down, the thoracic cage, it goes out. Okay, and that generates a negative pressure. This negative pressure pulls the air in. Okay, what happens during expiration? During expiration, the thoracic cage goes in, the diaphragm goes up, and that creates a positive pressure and it throws the air out. Okay, now first thing, we know over here the subglottis. It is made up of a complete ring of cricoid cartilage. Okay, above that we have the glottis. At the glottis we have the vocal folds, the thyroid cartilage, and they have a fixed anterior-posterior diameter. So at glottis and subglottis, suppose there is some mass. There is a mass, like we just discussed, there is a membrane, laryngeal web. Okay, so whatever this is, it will block the airway, both during inspiration and expiration. Okay, so we will have a biphasic stridor. Okay, So we will always have a biphasic stridor for any lesion that is there in the glottis and subglottis. Okay, now what happens at the level of the trachea? So we have the thoracic trachea, we have the bronchi. Now what happens at their level? You see, the trachea, the bronchi, they are all lined by incomplete C-shaped cartilages. Remember, we saw in the anatomy, they are incomplete C-shaped cartilages like this. So what happens? When there is a negative pressure, the lungs expand. Okay, and this negative pressure, it will pull the trachea and the bronchi. So this also expands during the inspiration. So airway diameter is more. In the trachea and bronchi, the airway diameter is more during inspiration. Right? Okay, so during expiration, what happens? During expiration, there is a positive force from everywhere. Now, because of this positive force, this diameter, it decreases. Okay, the diameter is less during expiration. So, any mass, any foreign body, any pathology in trachea and bronchi will cause an obstruction during expiration. Right? Therefore, trachea and bronchi, they cause expiratory stridor. Right? What about supraglottis? Now, supraglottis and pharynx. You see, supraglottis, we had the epiglottis. Okay. Now, supraglottis and pharynx, they are not so much bound tightly. Even the epiglottis is not bound very tightly. So, when there is a negative pressure, as we saw in laryngomalacia, there is a negative pressure, it collapses in. Okay, so the collapse is seen in negative pressure, that is during inspiration. So therefore, supraglottis and pharynx, they have inspiratory stridor. Okay, so therefore, we can divide this stridor into three types. What are the three types? It can be inspiratory, it can be expiratory, or it can be biphasic. Okay, inspiratory stridor is seen in a lesion of supraglottis or in pharynx. A expiratory stridor is seen in trachea, primary and secondary bronchi, whereas a biphasic stridor is seen in glottis and subglottis. So that's the rule, and this question is asked many times in the exam. You can see the NEET PG January 19, DNB June 18. Inspiratory stridor is due to lesions of. So now we know inspiratory stridor is due to supraglottis. Right? Okay. Most common site for laryngeal web is, answer we know is anterior glottis. Right? Okay. Now, before I finish this topic, I know many of you must be wondering that in case of subglottic hemangioma. No, I know subglottic hemangioma, I told you the patient has inspiratory stridor. Okay, patient has inspiratory stridor. That's what I taught you. I know you must be wondering that sir has just told us a rule that glottis and subglottis, there will always be biphasic stridor. But why sir has taught us that subglottic hemangioma has inspiratory stridor? Okay, to understand this, let's go back. Let's look at this photograph of the subglottic hemangioma once again. Now, what do we see in this diagram? We see this hemangioma. Okay, now, what happens during inspiration? During inspiration, there is a negative pressure. Okay, there's a negative pressure in the lungs, there's a negative pressure in the airway. Now, this negative pressure exerts pressure on this hemangioma and pulls the hemangioma in. Okay, so the hemangioma is pulled in. When the hemangioma is pulled in, more blood goes inside the hemangioma. So there is a pooling of blood in hemangioma. That means hemangioma size increases during inspiration. Okay, and when there is expiration, there is a positive pressure. This positive pressure pushes the blood out of the hemangioma. So hemangioma empties out during expiration. It shrinks in size. Okay, so this hemangioma grows during inspiration it shrinks during expiration, so therefore it blocks during inspiration. Okay, and therefore patient has inspiratory stridor. All right, you see, this hemangioma does not follow our rule, because you see the subglottis diameter is fixed, but this hemangioma, it itself grows during inspiration and therefore blocks mainly during the inspiratory phase, right? So that is why I said subglottic hemangioma has inspiratory stridor, whereas all the other lesions of the subglottis or glottis, they will cause biphasic stridor. Okay, so these were the congenital lesions of the larynx that I wanted to discuss with you. All right, thank you.